Welcome to our 198th webinar on approach to hypertension. And we welcome Alaka ma'am to take up this session. Ma'am needs no introduction. Thank you, ma'am, for joining. And we'll take up the questions at the end of the session.
Good evening, everybody. Today we are going to discuss approach to hypertension. The approach to hypertension, let me clarify in the beginning only. The hypertension that we are going to discuss is primary or essential hypertension. You all know that there is a primary and secondary hypertension. Secondary hypertension, there is some cause like renal hypertension or maybe endocrine problems. That the approach to them is different. This is primary or essential hypertension in adults. So a person above the age of 18 coming with hypertension, that is what we are going to discuss today. Now, what is a blood pressure? Before that, let me explain to you what is peripheral resistance. You all know that arterial walls are elastic. Why are they elastic? The heart is pumping out the blood for circulation. It pours the blood into the aorta to the arteries, to the arterioles, and then to the capillaries. Now, we also pour water or our water flows through the cement pipes or other pipes. Those pipes are rigid. So why can't our arteries be rigid? Because we are considering a biological tissue. Okay. Now, the demands, it depends on the demands of the body. If body wants more blood, then heart will pump out more blood. So the stroke volume will increase, the pulse rate will increase. And to accommodate that blood, the more amount of blood, there will be, the arteries need to be elastic. So there is a flexibility. Now what happens when there is before the aortic valve opens, the pulse wave is initiated. The pulse wave is going along the aorta. The pulse wave goes forward and the aorta becomes slightly dilated. The AV valve, the aortic valve opens and the left ventricle pushes the blood into the aorta. All that blood is accommodated in that little dilated aorta. Then pulse wave goes in front to the next point so that this blood goes there and this part becomes again the same. Therefore, there is a elasticity or elastic tissue in the arterial walls. It is a flexibility because of our body demands. Now, you all know that when we stretch a rubber or a rubber band, there is a little resistance. And this resistance to the blood which is pumped out by the heart is called as peripheral resistance. And peripheral resistance is the determinant of diastolic pressure. Now, against this diastolic pressure, when the heart has to push the blood or pour the blood into the blood vessels, naturally the heart will require more pressure. So, you all must be knowing what is called as isometric contraction of the left ventricle. The mitral valve is closed, the aortic valve is closed, and the left ventricle goes on contracting so that there is a pressure built up in the left ventricle. Then the aortic valve opens, and with that force and pressure, the blood is poured into the aorta. So this is the systolic pressure. The force with which the heart pumps out the blood in circulation, overcoming the peripheral resistance, is systolic pressure. The systolic pressure is always more than the diastolic pressure. The normal blood pressure, that as we all know, is 120 by 80 millimeters of mercury. The range is 110 to 70 millimeters of mercury. It will vary depending on your age, the activity, and the elasticity of the vessel wall. In India, what is the prevalence of this essential hypertension? Now, this ICMR study shows the prevalence in India is 29.8%. In urban area, it is 33.8%. That means 1 in 3 person is hypertensive. Just imagine, every third person is hypertensive. And in rural area, it is 27.6%. Okay. So overall prevalence is 29 or 30%. So remember, every third person coming to you may be hypertensive. It remains asymptomatic, and therefore, as a part of our routine examination, when we check the BP, we find that the person is hypertensive. Or the patient can present with complications of hypertension. We will discuss it little later. So the prevalence is 30%. What are the risk factors? It could be heredofamilial, like diabetes. It could be heredofamilial. Some genetic predisposition may be there. One second. The genetic predisposition may be there. So it is heredofamilial. Next, smoking. A person who is a smoker will have high blood pressure. Alcohol intake. And as you know, in India, people drink like fish. So alcohol intake is also a risk factor for hypertension. Lack of exercise. Most of the people nowadays working from home, they are in IT industry and whatnot, and there is absolutely a sedentary work. There is no exercise, and that is again a risk factor for hypertension. Caffeine intake. Now we all drink coffee, but maybe I drink only morning and evening. You also might be drinking 2 cups of coffee per day. But there are people who go on drinking coffee throughout the day. If you go to USA, in every office, there are so many coffee machines that people, while just talking to each other also, they will fill up the coffee and they will start. They only sip the coffee and the rest of the coffee is thrown out. But during the day, they may be drinking coffee 10 to 15 times. So this caffeine intake also will increase the blood pressure. Salt intake is another thing because the salt retains the water, and that again will be a risk factor for hypertension. And stress. The stress is the biggest factor for developing hypertension in young people. Our young people, very career-minded people, they are called as A-type personalities. A-type personality is a very ambitious person, wants to achieve more and more in a shortest possible time. What are the other risk factors? Obesity, diabetes, and dyslipidemia. They will decrease the elasticity of the peripheral vessels, will increase the diastolic pressure. When the diastolic increases, naturally the heart will have to increase the systolic pressure. And then there is another condition which is called as OSA, obstructive sleep apnea. Usually it is seen with the obesity. But people who have this obstructive sleep apnea is also a risk factor for hypertension. Measuring the BP. Now, when we were students, there were not so many gadgets. So we used to measure the BP only with the mercury sphygmomanometer. That time the life was easy. Medicine also was easy. But now so many gadgets have come, so many studies have come, and therefore every time it will go on changing. And therefore they call it as office BP measurement. Now, you know the Americans, they want to show that they are something different from the rest of the world. Rest of the world is using metric system. We talk in kilometers and kilograms. But Americans will talk about miles per hour. Okay? Because they want to be different. So similarly, British or Europeans will say the BP in the clinic, doctor's clinic. But for America, they use the word office. So your clinic is your office. So office BP monitoring, that means you measure the blood pressure in your office. At least take 2 readings. Then there is a home BP monitor. We have now gadgets, and a person, those they can measure their blood pressure at home. Then there is an ambulatory BP monitoring. Now this home BP and ambulatory BP, they are good for monitoring the therapeutic response. But for the primary diagnosis, it is a doctor who should take the office BP. The cuff of our BP apparatus should be the what we call it as a bladder of the cuff. It should be 12 centimeters by 35 centimeters. It should be tight around the arm, 1 inch above the cubital fossa. It should be uniformly tied. Also remember, it should not be tied over the clothes. I have seen, if I ask my staff nurses to take a blood pressure, they will take the blood pressure, tying the cuff on the sleeve of the shirt or sleeve of the kameez, and they take the BP. How can you auscultate with clothes on a brachial artery? So there are many fallacies when they take a blood pressure like this, and one has to be careful about it. So therefore, we have to take properly the office blood pressure measurement. Now, what is important that before taking the measurement, either in the office or at home, these things are to be avoided. Caffeine, no smoking, no bathing. Bathing is also a good exercise. No exercise. All this should be avoided for at least 30 minutes before taking the BP, because these are all known to increase the blood pressure. As a doctor, when we take the BP measurement, we should measure it in both the arms. We should measure it in supine and standing position. I'll tell you one very funny anecdote which had happened with me. One of my relatives, he just said, check my blood pressure. So I checked it. As doctors, we always teach the students also, I used to teach, that the doctor should examine the patient by standing on the right hand side of this patient. So I checked his BP. The BP was whatever, normal. Before that, I checked the pulse, and I checked the pulse in both the hands. It was, left side also the pulse was fed, right side was fed. So I took the BP. Then he went to his son's place, and there some another doctor came after 2-3 days. So he just asked him to check the BP. And doctor, by accident, he was standing on the left side. So he took the BP on the left side, and it was very low. So he called me and he said, could that be a difference in the left and right side? Then I called him back and examined him thoroughly. On the left side, the BP was very low. We investigated him, and there was a stenosis of the left subclavian artery. Okay? In the coarctation also the same thing can happen. Therefore, take the pulse on both the sides and also measure the blood pressure in both arms. Take it in supine and standing position. When we talk about orthostatic hypotension or the sympathetic response to a standing position, so it is better that we check the blood pressure in supine and standing position. We used to use mercury sphygmomanometer, which is now replaced by large dial aneroid manometer or by digital manometer. Now, as more and more gadgets have come, and because of the stress of the modern life or the changing lifestyle of the modern era, so many diseases are becoming more common. So as we get more and more information, everybody develops their own guidelines. So we have many guidelines for the management of hypertension. This is Joint National Commission guidelines, European Society for Cardiology guidelines, WHO guidelines. We have Indian Hypertensive Society guidelines. Now, I have gone through all these guidelines and made the topic simpler for you. But at the end of my lecture, I have given you the guidelines also, which you should go through. What are the Indian guidelines? Indian guidelines say if the office BP measurement is more than 140 by 90 millimeters of mercury, this is a threshold for treatment. Home BP measurement is more than 135 by 85, should be taken as hypertension and start the treatment. Ambulatory 130 by 80. Okay, so the parameters go on changing. Once we start the treatment, what should be the treatment target? When we can say that the blood pressure is controlled. If the age of the patient is less than 60, the BP should be controlled to a level of 130/80. If the age is more than 60 years, the systolic BP could be 140 and diastolic should be between 80 and 90. Above 90 is hypertension. Now, this is a JNC classification. This is Joint National Commission. Okay. And they have given normal category, systolic less than 120, diastolic less than 80. When the systolic is between 120 to 139, now just to avoid the confusion in the lecture, this 139, 159, therefore I am giving you a simplified version, but at the end I have given you all the guidelines. You can go through that. Now, if the systolic is 120 to 139, that means systolic is slightly more than the normal, and or diastolic is 80 to 89. This they have classified as pre-hypertensive, like pre-diabetes. This is pre-hypertension, 120 to 139 by 80 to 89. Approach will be little different for these people. Blood pressure, above this is a blood pressure. So stage 1 hypertension is 140 to 159 systolic and diastolic 90 to 99. And stage 2 hypertension more than 160 and diastolic should be more than 100. When I was a student, we used to classify this as mild, moderate, and severe. And it was so simplified at that time. I still remember Dr. N.G. Talwalkar telling us that when you see the BP, take the age of the patient into consideration. So 100 plus his age is a normal systolic for that patient. So if the patient is 70 years old plus 100, that means his systolic 170 is normal for him, because at that time we used to think it is because of atherosclerosis, aging process, that the systolic BP will be high. But that is not true today, because there is a lot of evidence that with this high systolic pressure which is high, there can be more coronary events, there can be more stroke events, and therefore we have changed the definition. So as I am showing you here, the BP 140 to 159 systolic and diastolic 90 to 99, that means less than 100, is stage 1. And if it is more than 100 diastolic, it is stage 2 hypertension. So if it is pre-hypertension, we can warn the patient, we can change his lifestyle. And in this pre-hypertension phase, you can call the patient after 1 month to recheck the BP. So after a lifestyle modification, if the BP is again high after 1 month, he needs a pharmacotherapy. What are the investigations once we find that the patient is hypertensive? What are the investigations that we should ask for? The first is ECG. Because as I said, with this increased diastolic pressure, when the left ventricle is pushing the blood or pouring the blood into the aorta under a great pressure, the left ventricular muscles also will be hypertrophied. So ECG will show left ventricular hypertrophy. If there is a left ventricular hypertrophy, it indicates the high blood pressure is of some standing. So it is not 1 or 2 days old. It must be there for at least a few months. 2D echo will also tell us about left ventricular hypertrophy. At the same time, it may throw some light on coronary artery disease also. Diabetes is a predisposing risk factor, and many times, as I told you, like hypertension, even the diabetes remains undiscovered. And therefore, when a patient comes with hypertension, we should do blood sugar fasting PP. Serum creatinine to find out whether the hypertension has affected the kidneys at this stage, because our management will also be decided by this. And serum lipids, cholesterol, triglycerides, LDL. Dr. Asrani has taken a beautiful lecture on dyslipidemia. So these investigation, in addition to your other investigation, is a must. So ECG, 2D echo, blood sugar, serum creatinine, and serum lipids. What are the complications of hypertension? Why should we treat it? because this hypertension per se may give some symptoms, but more than that, there are dreadful complications, cardiovascular complications, and most important amongst them is myocardial infarction, coronary artery disease. Stroke is more dreadful than that. Cerebrovascular accidents. Either it may be a cerebral infarct or it may be a cerebral hemorrhage, still worse. Hypertensive kidney disease. A long-standing hypertension will also affect the kidney function, and finally, we call it as a hypertensive kidney disease. Finally, lands up into a renal failure necessitating dialysis and hypertensive retinopathy. Okay, and therefore it is necessary to treat the hypertension. Your patients may say, I don't have any symptoms, I don't have this, I don't have that, why should I take the treatment? Because once you start the treatment, it will be lifelong. So with all blah blah they come, they're very reluctant to take the treatment. And therefore, you must tell them that these are the complications which are dreadful, and therefore, it is better that we control the blood pressure so that we can delay or prevent these complications. The salt. The recommended salt intake is less than 5 grams per day. And how much salt we Indians are taking? And we are taking more salt these days because most of our younger generation, they're getting so fascinated by American food, processed ready-made food, which has very high salt content. Dairy product, high content. ICMR study shows the daily intake of salt in Indians is 13.8 grams per day. All our food already contains sodium chloride. In addition, we add sodium chloride, the salt, and plus we take table salt. So daily intake is 13.8 grams. In North India, it is 14 grams. In East India, it is 9.8 grams. West India, that is all of us, 10 grams. South India, 9.4 grams. It's almost same. So the recommendation is less than 5 grams per day. So we have to curtail down on our salt intake. So what will be the management? Coming to the management, the first and foremost is lifestyle modification for all stages of hypertension. And as I said, you have to take at least 2 readings before we start the drug therapy. So this lifestyle modification holds true mainly for pre-hypertensive. I mean, pre-hypertensive patients can be controlled only with the lifestyle modification. But the lifestyle modification is for all the patients in all stages. But if it is pre-hypertension, please counsel the patient and convince him that these modifications will control his blood pressure. He will not develop blood pressure in near future, but he must monitor. What are these lifestyle modifications? Weight reduction. If he is overweight, he should reduce it. For which aerobic exercises. Now, our older people, as well as our most of the elderly women, they don't go to the gym. Nowadays, younger generation, it has become a fashion that they will not do otherwise exercise, but they will go to the gym and pay big fat charges to the gym. So that is okay. At least if they are maintaining health, it is good. But when they go to the gym, they should not take their products like the protein products they give and something else that they give. The other day only I had a patient. He came with gynecomastia. It was not a gynecomastia. It was a hypertrophy of the muscle. He is a gym trainer. He himself takes steroid injections every day to build up his muscles. So these are all erroneous things, and therefore we must correct them in our patient. So weight reduction, aerobic exercises, the best thing will be brisk walking. At least 5 days in a week, brisk walking will help to maintain your stamina, to reduce your weight, to control your hypertension, and also to control your blood sugar. And therefore, brisk walking we have to advocate to our people. Reduce the salt intake. no tobacco. Okay, and then come to caffeine and drinks. 2 drinks per day. If you can't live, I mean, abstinence from alcohol is the best. Abstain from alcohol. But if you just can't live without alcohol, only 2 drinks per day can be allowed. Yogasana. Now, nowadays we only call it as yoga, yoga. It is not yoga. It is asana. Asana, which is exercise, which increases your stamina, increases your breathing capacity, and tones up your body. So, yogasana and meditation. Meditation will relieve the tension, the stress, the anxiety, whatever are the causes or predisposing factors for hypertension. What we have to, even at the pre-hypertension stage and thereafter at every stage, what we have to emphasize on our people is lifelong treatment. Once you start the treatment on hypertension or once it is hypertension, he has to take treatment which will be lifelong. We can control the hypertension, we can control the blood sugar, but we cannot get rid of hypertension. Once it has developed, it is going to remain. Therefore, lifelong treatment is necessary, and therefore he has to be compliant with the lifestyle modification as well as treatment compliant. What is third thing which is important for him? Regular monitoring. That once they come to you, they get their BP checked up, you start some treatment, and then they never turn up. They take it for granted that with this, my blood pressure is normal. I have seen quite a few patients who tell me, no, when my blood pressure increases, I get the indication. I know my BP is high. When my sugar increases, I know my sugar is high. How do you know that? It's not written on your forehead. We have to check, we have to monitor. That only will give us the idea what is your blood pressure and what is your sugar with the treatment. In spite of the treatment, whatever we have given, if your BP is not controlled, we will change the treatment. We'll add some more drugs so that the blood pressure is brought under control. So in your first visit only, when you talk to the patient, counseling regarding lifestyle modification, no smoking, no alcohol, yogasana, meditation, and then emphasize on him the treatment is lifelong, compliance is expected from him, and regular monitoring of the blood pressure is necessary. Then we have to develop a strategy. What will be the strategy? There are 4 groups of drugs. There is one school which says start with one drug, titrate to maximum dose, and with the maximum dose, if it is not controlled, then only add the second drug. Another strategy says start one drug, then add a second drug before achieving the maximum dose of the first one. The third category says begin 2 drugs at the same time as separate pills or combination pills. And in our setup, most of our pharma industry people and MRs who come and brainwash us, we always have some combination pills. Of course, if there are 2 drugs in one tablet, the compliance improves of the patient because he has to take only one tablet a day. But then may not be scientific, but that is available, so we have to use, because there are other factors also, the patient's affordability, compliance, how often he can take it, feasibility, and therefore your third strategy is begin 2 drugs at the same time as separate pills or combination pills. And the last is initial combination therapy is recommended. You start only with a combination therapy. You start with combination therapy when the blood pressure is in stage 2 or higher. So if there is a high BP, diastolic more than 100, 110, 116, then we have to start a combination therapy of 2 or 3 drugs right from the beginning. I think one slide is missing here. Okay, what are the drugs which are available at our disposal? I think that slide is somewhere misplaced. It is A, B, C, D. A is for ACE inhibitors or ARBs. B is for beta blockers. Now, beta blockers are used only in certain conditions with hypertension. So it is not the first drug of choice. So A is ACE inhibitors and ARBs, angiotensin receptor blockers. Then beta blockers. C is calcium channel blockers. And D is diuretics. So A, B, C, D. Diuretics are good drugs because our salt intake is more and we can start them right in the beginning. Or we can start it with a combination therapy. What are the diuretics which are available to us? Hydrochlorothiazide, we can use it in the range of 12.5 to 50 milligram. Chlorthalidone, 12.5 to 25 milligram. Indapamide, triamterene, which is a potassium sparing. Spironolactone, again a potassium sparing. Amiloride and furosemide. Okay, and these are the diuretics we can use singly or in combination. ACE inhibitors. Which are the ACE inhibitors we can use? Lisinopril, benzapril, fosinopril, and quinapril. The dose is 10 to 40 milligram of these drugs. So you start with 10 milligram, go on titrating, go to the maximum dose. That is your strategy 1. Or after going to 20 milligrams, if it is not getting controlled, add another drug. So lisinopril 10 to 40 milligram, ramipril 5 to 10 milligram, trandolapril 2 to 8 milligram. The only troublesome side effect of this ACE inhibitor is hacking cough. Very dry cough may cause dizziness and giddiness in the patient. So if the patient is really getting a dry cough, please change the drug. Then we have ARBs, candesartan 8 to 32 milligram, valsartan 80 to 320 milligram. These are maximum dosage. Losartan 50 to 100, olmesartan 20 to 40 milligram, and telmisartan 40 to 80 milligrams. Okay, so remember these drugs and accordingly get used to one combination of drugs so that you get confidence of treating the patient. Another group is calcium channel blockers. Dihydropyridines like amlodipine, the dose is 5 to 10 milligrams, or nifedipine extended release is 30 to 90 milligrams. But nowadays we don't use much of nifedipine, we go for amlodipine. The side effect of amlodipine or these calcium channel blockers is it causes little palpitation. So please tell the patient as a counseling that it will cause temporarily, which may last very briefly, some palpitation. Another side effect that the patients are always worried is little edema around the ankles. If the edema becomes more and more, then add diuretic or change the drug. But please caution the patient that this happens as a side effect and there is nothing to worry. Because our patients have knowledge from all over the world, Ayurveda, homeopathy, and whatnot. And the moment they feel that there is hypertension and 5 hours suze, edema of the feet, that means my kidneys are affected. So such half knowledge is more dangerous. So please tell them that this may cause little edema around the ankle, but nothing to worry. If it is more, we will take care of. Then non-hydropyridines are diltiazem and verapamil. Okay, so you can use these drugs. You can start amlodipine 2.5 milligrams also and go on building the dose. Now, when we talk about beta blockers, we have to use selective beta blockers, possibly safer in patients with COPD, asthma, diabetes, because beta blockers otherwise mask the hypoglycemia. Therefore, we have to be careful, and peripheral vascular disease. So patients may be having any one of these diseases, and therefore the safer beta-1 selective beta blockers are metoprolol, bisoprolol, betaxolol, and acebutolol. Metoprolol dose is 50 to 100 milligrams. Nebivolol is 5 to 10 milligrams. Propranolol 40 to 120 milligrams twice daily. Carvedilol, these are the new beta blockers, much safer with no side effects. Carvedilol 6.25 to 25 milligrams twice daily. Bisoprolol 5 to 10 milligrams and labetalol 100 to 300 milligrams twice daily. So these are the beta blockers. When can we use them? They are mainly used with these complications. If a hypertensive patient is having heart failure, then this is the treatment we can use. ACE inhibitor, ARB or ARBs, plus beta blockers, plus diuretic like spironolactone. Post-MI or coronary artery disease, ACE or ARB and beta blockers. Coronary artery disease, ACE or beta blocker and diuretic. If the BP is not controlled, calcium channel blockers. Diabetes, again the same because it is also renoprotective. So we can use ramipril, ACE inhibitor, ARB, calcium channel blockers and diuretic, depending on the blood pressure measurement. Chronic kidney disease, ACE and ARB. And if there is a recurrent stroke, it can be prevented by using ACE inhibitors and diuretics. So this is what I wanted to share with you, that the BP measurement is office BP measurement. Take it twice. If the patient comes in a pre-hypertensive stage, then you can tell him about that the BP is slightly on the higher side. Follow this lifestyle modification and come after 3 weeks and we will check it again. If after 3 weeks also the BP is high, then after that means lifestyle modification is not working, so start pharmacotherapy. If the patient comes to you and first time when you check the BP and the BP is between in a stage 1, so 140 by 90 to 95, then ask him to come again after 3 to 4 days and check it again. If it is high, that means you have confirmed that he has hypertension and start the treatment. But if the patient comes with this 140 by 100 or 150 by 100, plus he has some of these target organ damage, then you have to take it within few hours, confirm that he is hypertensive and start the treatment. Now, these are some of the guidelines that I'm sharing with you. At leisure, you go through them. I have given you the gist from the same guidelines. Okay? As I said, the threshold for starting the treatment in India is BP more than 140 by 90. And whatever target level is, target value is 130 by 80. So if it is more than 140 by 90, that is the threshold for starting the treatment. Now in the guidelines, there is, they have gone into very details like research
Sorry,
work.
ma'am, the slide is not seen, the guidelines.
No, I'm showing it.
Okay.
So what I'm saying that there are various guidelines they have developed as per the needs of their country. They have also developed guidelines for clinical practice group. And what I have said is based on the same guidelines. I mean, I have not invented anything. But if I start talking in my lecture, 130 to 139, 140 to 149, you will get confused. Therefore, I have given you the Indian guidelines more than 140 to more than 140 by 90. But I am giving you here the guidelines, which at leisure you go through and decide how you are going to start the treatment. So first of all, measure, it is an office BP measurement. Measure it twice to confirm it. Carry out the investigation, because if you find the lipids are high, dyslipidemia, that also you will have to treat. Aspirin has no role in this treatment of hypertension, but ECG, echo, If that shows you anything else, or if the blood sugar is high, you will have to start a concomitant treatment for this. If it is a pure hypertension, then decide your strategy. Are you going to use only one drug? Are you going to use the combination of drugs? At what level you will change the therapy? So all this you decide, and then you start the treatment. But the most important is counseling of the patient, that he must be compliant with the lifestyle modification and drug therapy. And what is most important, that once we start the treatment, it is not the end of it. I always tell the people that antibiotics have a fixed dose and duration, but that is not so for diabetes and hypertension. So monitoring is very, very important, and therefore call the patient at least once a month to check the blood pressure. Now these are the guidelines, as you can see here. These are the guidelines recommended for pharmacological management of hypertension. In detail, they have given you what should be the threshold and what is the target. Now, there are American guidelines, that is Joint Commission, JCN guidelines. Then there are European Society. Then there is Indian Society of Hypertension. Okay. So this is one table that I am showing you. What is the BP target? What should be the measurement? Ambulatory measurement, home-based measurement. Now, for everyone, it is not possible in India to carry out ambulatory measurement or home BP measurement. And if they are carrying out also home BP measurement with that digital machines, these people either the batteries are low, or they are not sitting properly, they are not taking proper precaution to tie the cuff, and therefore the reading are always erroneous. Yeah, I prefer that the patient should come to my office and I'll check the BP. So these are some of the guidelines. Now this is combination therapy again, and the frequency of follow-up. So please go through these guidelines. Target time for BP control, that also they have explained. They are saying 3 to 6 months if the BP is 140 to 160 by 90 to 99. I mean, I will not agree with it, because I would control this BP. For me, this is very mild BP. I will control this within 15 days, but then I will keep on hammering on the patient about the compliance. Okay, so you have enough time, 3 months, that you will be controlling 140 by 100. So similarly, timelines also, these guidelines are given. Now these are Indian Clinical Practice Group guidelines. Okay, now under this, there are WHO guidelines, there are Ministry of Health and Family Welfare guidelines, and there are this IGH group. Now in spite of doing all this, when the patient's BP is not coming under control, it is better that you refer the patient to a specialist. These are some cases of resistant hypertension, and we have certain newer drugs or newer therapies. Either we can use injectables and bring down the BP, or there are something called as denervation techniques, and thereby we can treat this hypertension. But always emphasize, if left untreated, this hypertension will lead to complications. So these are again 2021 guidelines. There are American Heart Association, European Society, there is Indian Society of Hypertension, and CPG, Clinical Practice Group guidelines. So I think that is all that I wanted to share with you. If you have any questions, please mail them to Preeti, and then I will answer all your questions at leisure. But before that, whatever I have spoken and whatever guidelines you are going to read, let that sink in, you understand it, and then please send your questions. Thank you very much for your patient hearing.
Thank you,
Okay,
ma'am.
Preeti? Thank you.
Yes, ma'am. Thank you, ma'am, for enlightening us with your valuable insights on this topic. We deeply appreciate your time and expertise. And thank you everyone for joining today. Actually, there is a glitch on WhatsApp, so I couldn't convey the webinar details to everyone. So it's a kind request that you just share all the information within these 2-3 days, whatever the video recording and everyone with your friends, so that we can reach maximum. people, and we'll soon resolve this glitch. Thank you. Thank you for joining today. Thank you, ma'am.
Thank you. Good night.
Good night.